Mia, a resident in family practice from Victoria. Victoria, I think maybe through Jane we can kind of distribute that information. The next one is Dealing with Heterogeneous Group of Students by Dr. Luke C., a resident in the Family Medicine program here in Vancouver. Luke, hi. Congratulations. And the last but not least is called Turn on the Technology Tap to Fill the Knowledge Gap. This one could win an English Literature Prize, probably. It's by Dr. Diane Villani, a fellow in geriatric medicine from Vancouver. So let's give all of them a grand round of applause. So once again, for each of the winners of the 12 tips, they will receive a certificate from the UBC Office of Faculty Development. They will receive a brand new iPod Nano with the color of their choice, I would imagine. And they will have an opportunity to collaborate in authorship for a 12 tips paper for the medical teacher submission of the 12 tips of teaching in a distributed medical education program. And that we will be getting on in the next 6 months or so, depending on how fast the turnaround is going to be. So I do want to say on behalf of our Office of Faculty Development, thank you everybody for submitting entries. The response this year is very nice and very, very popular. We are going to do this again next year. And next year we're going to have a different theme for 12 different tips on something related to teaching. I have some idea already, but we'll let me mull over it a little bit more, and then we're going to make an announcement. And maybe the next time it is iPad rather than iPod. I imagine what would happen if I say the prizes are iPad, but yeah, you get a lot more submissions, all from the same people. But anyway, it gives me great pleasure here today to welcome all of you again to our monthly rounds for medical education. And in fact, I saw that one of our winners just walked in.
Yay!
Hi, you won something. But it gives me great pleasure to introduce two, actually, of our speakers for our keynote presentation this afternoon. First is Dr. Shafiq Duramsi, and as many of us know, Shafiq is an assistant professor in the Department of Family Medicine, as well as the associate director of the Center for International Health, and in fact has done tremendous work in the area of health advocacy, trying to talk about not only implementing in a curriculum, both undergraduate and postgraduate, but also from a social accountability point of view. For those of us who are involved in undergrad medical curriculum renewal, we know that social accountability is kind of the buzzword now, is kind of the key thing. And we're really pleased to have Shafiq actually joining us today. And in particular, if I may mention, I mean, clearly there are many connections between Shafiq and us, but the one in particular is that he is one of our past winners of the Faculty Development Initiative grant. So we are particularly pleased to have Shafiq coming back to share his work with us. We are also very happy and honored to have Dr. Farah Shroff presenting the second part of the keynote today. Farah is a public health researcher and educator, and again, very passionate in her work in health advocacy, specifically not only locally in the Vancouver downtown east side area, but also in other parts of the world, including in Latin America, Northwest Territories, etc. And she is currently an adjunct professor in the Department of Family Medicine at UBC. So without further ado, I'm going to pass this hot seat over to Shafiq, hopefully not too hot. And I believe the title of the presentation today is Preparing Future Physicians for the CanMEDS Health Advocate Role, a Work in Progress. So Shafiq.
Thank you very much, Roger, for the kind introduction. And I'm looking forward to all that coffee. You can never get enough coffee when you're an academic, I think. So today's presentation will focus initially, the first half of it, I'll focus on the health advocate study that is currently underway, that's funded by the Royal College. And I will talk a little bit about some of the preliminary findings, some of the literature review behind that study, And then we'll talk about the Faculty Development Initiatives grant that we received to help further support that study in terms of knowledge translation. My co-investigator in that is Dr. Farah Shroff. And I also want to mention that we were very fortunate to have Lisa Mew, community medicine resident, who is completing her research with us on what inspires residents to participate as health advocates. Farah will talk a little bit about that as well. So the Preparing Future Physicians for the CanMEDS Health Advocate Role, that's funded by the Royal College, is a qualitative study, and it seeks to explore the perspectives of the role and how related competencies can be best addressed pedagogically in medical training. So for well over a decade now, there have been persistent requests for medical schools to be socially and community responsive, particularly to improve medical training, to better prepare future physicians to identify and collaboratively address the broader determinants of health. In Canada, the growing concern around social accountability and educating future physicians to respond to the needs of vulnerable people in particular is considered now an attempt to protect and to uphold the social contract between medicine and society. And that's a literature that, a lot of that literature points to that. Of course, there's more literature. I've just highlighted some of the key pieces up there, and I suspect this PowerPoint will be made available to people so that you can look you can go back to see what literature I've cited. Our accreditation bodies are also concerned about healthcare disparities, and now accreditation standards require that we ensure that future physicians are taught about health disparities and the development of solutions to these burdens, the importance of meeting the healthcare needs of medically underserved populations, and about core professional attributes such as altruism and social accountability. Notice the words that are being used. I mean, altruism. And in my study, I've explored, how do you teach altruism? How is it learned? Can you assess it? So some very, I think, heavy and philosophically loaded terms that we're being introduced to. We just need to have more of a practical sense of what this might look like in training and in learning and in assessment. In response to this, the Royal College established a framework, as you know, of essential physician competencies to demonstrate a commitment to meeting, quote, societal needs through, quote, better standards, better physicians, better care. And CanMEDS, called the Canadian Medical Education Directions for Specialists, is organized around these 7 roles, as you know, and it's being adopted and adapted around the world into accreditation standards, training objectives, evaluations, and certification. The health advocate role, well, before I get to that, the non-medical experts role generally introduce relatively new skill sets for physicians. Now, certainly, if you speak to some disciplines, they will say, no, these skill sets have been around in our discipline, and we've been training around these skill sets for quite some time. But many of the surgical specialties would suggest that these are, in fact, relatively new skill sets. And the health advocate role in particular relates specifically to the physician's, what I would call, social responsibility to identify and respond to what Frank and others have said, the needs of vulnerable or marginalized populations, and to attend to the ethical and professional issues inherent in health advocacy, such as altruism, social justice, autonomy, integrity, and idealism. Again, look at some of, social justice, certainly there's a lot of literature around that. We have some sense of autonomy and integrity, but idealism, when you talk to students who are applying to medical school, you'll see idealism in that discourse. And then how that evolves over time has become a very interesting research topic. I just wanted to summarize some of the key and enabling competencies in the health advocate role. As you might recall, there are 4 key competencies, each having enabling competencies. And what I've done is I've just adapted and adopted them as a summary in this slide. And so this is what CanMEDS says. As health advocates, and this is the definition at the outset, physicians responsibly use their expertise and influence to advance the health and well-being of individual patients, communities, and populations. And then you have the enabling competencies, identifying opportunities for advocacy, health promotion, and disease prevention, and I've bolded that because that's the central theme in one of the key competencies. So identifying that in the communities that you serve and responding appropriately. So it goes beyond just the ability to identify these, but to in fact then respond to them. And that's, I'll talk about later how that's being perceived. Identifying the determinants of health of populations, including barriers to access to care and resources, and then another caveat, and to implement a change. So during your training, residents are supposed to think about at least one way to change some of the barriers, and to go ahead and do so to demonstrate that they've learned how to do that. And lastly, to identify vulnerable or marginalized populations within those served, and again, respond appropriately. Back to the literature. The literature suggests that the health advocate role is regarded by educators as one of the more difficult CanMEDS roles to integrate into medical education. And there's little research that's been conducted on how medical educators perceive this role and how it can be effectively taught, integrated into the curriculum, and subsequently into clinical practice. And then what's of significant concern is, well, how do you assess this? Right? I'm just going to point to the leverage study, the first one on that slide, which sought to assess urology residents' perceptions and attitudes towards health advocacy in residency training and practice. And the methods that they used was the administration of an anonymous, cross-sectional, self-report questionnaire to all final urology residents in Canadian training programs. And it was a close-ended survey, and it employed a 5-point Likert scale. And they concluded in that study that despite the knowledge about and acceptance of the importance of the health advocate role, there is a perceived lack of formal training and a dearth of participation during urological residency training. And my research, there are some of the preliminary findings. I've interviewed 14 specialties, including subspecialties, and I'm basically getting that same information. I'm just going to highlight very quickly the study that the Royal College has funded. Ian Scott is my co-investigator, and then I have also co-applicants, Bob Woolard, Rick Mathias, Janusz Kaczorowski, and a colleague from Australia, Peter Harris. So we conducted interviews and focus groups to explore program directors' perspectives on the role of the health advocate and how the competencies related to advocacy can best be addressed in residency training. Now, I was fortunate also to be given the opportunity through UBC to complete the RCPSC Train the Trainer course on health advocacy, and so that's something that I do mention when I begin my interviews and my focus group. And inevitably, before the interview begins, most program directors say, so now I know who to go to. And so what's happened, in effect, is that my study has turned into an action research project because I'm now being invited to various specialties to facilitate academic half-days and rounds around the health advocate role. And what's that led to, beyond just speaking about the health advocate role, is an opportunity to sit down with the program directors and residents and to begin to think about how the health advocate role and the related competencies might best be integrated into training. I'll just share with you some of the preliminary findings from the interviews and focus groups. Time is certainly among some seen as a concern. How will we fit all of these competencies into an already overcrowded curriculum? particularly those who feel that the medical expert role needs to be mastered before you can begin to think about anything else, suggesting that perhaps some of the non-medical competencies are seen independently and outside of the medical expert role. So that's perhaps one of the barriers. Many specialties are inclined to undervalue the health advocate role, questioning its importance really in training vis-a-vis health outcomes. And then when those challenges come up, certainly there hasn't been a sense of what's in the literature to suggest how addressing the social determinants of health or looking at health promotion and prevention can in fact have a direct impact on health outcomes. Lectures are certainly seen as a dominant approach to teaching the health advocate role, but there is now an increasing sense that this isn't enough. Various specialties are beginning to develop case studies to share with residents. However, there still hasn't been the connection between learning through didactically and through case studies to implementing this in practice in any particular way. So that's another gap that we're noticing. Some have said that residency training can't teach you advocacy. Some talk about how you're born, or at least you're socialized very early to begin thinking about some of these issues of idealism and social justice, and that it's very difficult to teach it at the level of university education, although the literature would suggest to you otherwise, and this is literature particularly in education. Many have said that it's something that you learn on the job, and in my discussions and interviews, people have said, well, we model this in the clinic, and I say, what does that really look like? If you can just tell me what this modeling looks like, what examples do you draw on, what are some of the specific examples that you can give? And there isn't really a clear sense of that, but there is a sense that somehow this does take place through modeling. So it's still very nebulous, and I think the challenge many are facing, particularly within the context of accreditation, is to make this more concrete, tangible, and practical. Overwhelmingly, mentorship is seen as an important aspect around health advocacy, and to understand what people have called the levers of political power and how advocacy can help population health. One quote that Lisa shared with us from her interviews with residents and faculty: until you're in the job and a player in the political scene, it's difficult to understand how to become an effective advocate. This is the case study that I begin with in most of my grand rounds around this topic, or medical education half days. I start off by presenting, your department has recently had a Royal College review and received accolades for strengths in the medical expert role. However, the department has been cited for deficiency in the health advocate role. And of course, when I say that, you see a smile in many people's faces. The residency program committee has been gathered to discuss the matter. The committee has brought in an expert for advice. The expert suggests that efforts to integrate health advocacy into the training program is likely to be more effective if it's undertaken using a participatory approach, actively involving learners and residents. The committee is convinced and decides to involve the residents in reviewing the identified weaknesses. I've said urology because that was the last grand rounds I did. In reviewing the identified weaknesses in the existing curriculum, and to develop a plan to correct them with a focus on the health advocate role. A session with the residents is organized. The expert gives an interactive presentation on the role and invites questions at the end. After an awkward silence, one resident says, "Health advocacy is important, but we really need to develop proficiency in clinical and surgical skills. The other stuff we can figure out later, once we get going into our careers." Several residents nod in agreement. Now, with every specialty that I've presented this case to, there's an overwhelming identification with it. And so that's, again, it suggests this is how I've taken some of my findings, the preliminary findings, and have developed this scenario to give people a sense of what some of the impending challenges are. So last year, when the Faculty Development Initiatives grant opportunity came about, in my discussions with my colleague, Dr. Schroff, who's quite experienced in health advocacy, we talked about whether, it would be too soon to apply for such a grant given that the study isn't finished. And we realized that perhaps not. I think that parallel to this study, we realized that we need to develop some sort of hands-on teaching resource for faculty and for residents. And that's a proposal that we put forward. At this time, I'm going to hand over to my colleague who will talk about where we've come with the FDIG grant.
Thanks, Shafiq, and hello to everybody who's distributed around the province. Great to see you on the screen, and hello to everybody who's here. I just want to acknowledge that there is another member of our research team here, Joanne Oswetum, who's there, and I want to acknowledge Deborah Handberg, who's not here, as well as Lisa Mu, who's our resident who's working with us, and to thank all of you for what's been a very, very fruitful project in trying to tackle some of these issues that Dr. Dharamsi has raised. And really one of the biggest issues that we're trying to engage with is something that isn't really that new. Health advocacy isn't really that new, not in the world of Canadian healthcare in general, because in 1974 in Canada we came out with a report that started other reports all over the world in looking at these issues of what else makes us healthy besides medicine. So Canada has been a leader in this area for decades. It's just recently, since about 1995, that now Canadian medicine has jumped on board with this whole area of health advocacy. So it's borrowing some of the language maybe from the legal profession and trying to look at what does it really mean to try to work upstream. And so we're trying with this small enterprise of writing this e-booklet to try to inspire residents to work upstream, to try to look at all this literature that's come out within our own country as well as around the world, to see how important it is to try to make populations healthy. Because if we ask our physician colleagues, and Dr. Dharamsi and I are both PhDs, why do you do what you do? Well, almost everybody says to help people and to help people get healthy. And what the literature in this area has taught us is that the roots of health, salutogenesis, there's a whole discourse on this field called salutogenesis, is about looking at what really are at the roots of social health. And so we know that eliminating poverty or looking at better income distribution and eliminating unequal social status would make a huge difference to making people healthy. And that's really what health advocacy is about, is looking at these larger issues and to try to inspire our students, our medical students, and our residents to do this work that's upstream. So let's take a look at what we've tried to do here. So we received this grant, and what we're doing with this grant is can I just get this screen here so that I can see it?
No, that's not a screen.
Okay. Okay, thanks. Right. So what we're trying to do is to try to create a primer for our postgraduate colleagues in order to be able to teach this topic. And I think what strikes us, and you've just heard what Dr. Dharamsi said about the study that he's doing right now.
Speak is good.
Okay, thanks. That this topic is something that our colleagues aren't so familiar with at this point. So what we're trying to do with this primer is to try to help postgraduate medical educators to teach something that they're not so familiar with at this point. And beyond being a little bit unfamiliar, the concept of health advocacy is maybe still a little bit suspicious. It's still rather new. So what we're trying to do with this primer is to just give a little taste of what this field is about. So what are some of the barriers? Well, I just mentioned some of the barriers. That there's this lack of formal recognition. There's lack of monetary rewards, and really, what we hear in interview after interview, there's a lack of time. Physicians are already doing so much. Trying to keep up with clinical work is already too much. So trying to add one more thing into the physician role seems like an extra burden, particularly when there aren't a huge number of role models within Canadian medicine today to say, why don't you try doing this? There are some role models, and that's a good thing, but there certainly isn't a huge impetus. And so we're trying to we're trying to work in a very humble way in this area. So even looking at the definition of health advocacy, Shafiq raised some of the issues from the literature. They vary very widely. We've asked almost at the beginning of all of our interviews, and our resident Lisa Mu is doing a lot of interviews specifically asking residents, so what is it? What is health advocacy? This concept's been around for maybe 30 or 40 years in Canada and around the world, and what does it mean? Most of the people we've asked, and I think this is true for the study that Shafiq and Ian are doing as well, is the definition comes up to being individual patient advocacy. So that means basically standing up more for your patients. When your patients need better care, that means making that extra phone call, being there in the wards for them, and standing up for the patient to make sure that they're getting as good care as possible. So really being there and advocating for each patient. And that's considered already going a little bit beyond what some people see as their role. Then there are some people who see political lobbying as being an important aspect of health advocacy. So Shafiq also mentioned the tensions in doing that. So what would that mean? If you're really interested in looking at, say, the issue of homelessness, political lobbying would probably be a really important aspect of doing that kind of work, because it would mean looking at social policy and housing policy in the place where you're working. So yes, some of the people we've interviewed do see political lobbying as part of health advocacy, and certainly the literature sees it that way. There's quite a broad international literature which sees political lobbying as the key component of health advocacy. And there's certainly a tension there. So what really is the definition of health advocacy? Is it about looking at blaming, the literature basically says, are you blaming the system or are you blaming the individual? And when you're blaming the system, that's where you go more towards the political lobbying end. And when you're looking more at the individual end, you look at more at trying to take care of that individual person's health, because you say that person's lifestyle needs to change. So there's quite a tension. It's a very exciting literature if you're somebody like me who finds those things interesting. I find it very interesting. And then what we've also found is that a lot of the health advocates we've interviewed have gotten their inspiration by working abroad. That means working in the so-called third world or the south world. And there's an interesting disconnect with talking to people when they talk about doing health advocacy work in another country. So they get really excited talking about a project in Uganda, and we certainly have a lot of faculty colleagues who work in Uganda. Maybe you'll even know some of them. They get very excited about that work because being in a situation where there's a huge amount of poverty and people are really, really suffering, the altruism comes out. So people are okay to go without sleep for 2 or 3 weeks and then come home and go back to the 9-to-5 job. So we're finding that the impetus, the original inspiration for a lot of people who are interested in health advocacy comes from working in an African, Asian, or Latin American setting. Sometimes that does translate to working in a Canadian setting, and sometimes it doesn't. I'm going to read just a little bit of one of the interviews that one of our residents said. One of the people we chose to be a health advocate. What did she say was the definition of health advocacy? She said she hadn't thought about this before, and that's really typical of the interviews that we've had. She said, so I haven't thought about this before. Health advocacy, I guess, I think of it either on the individual level or the population level. And as a clinician, as a healthcare advocate, I think it's not only looking at the medical challenges that a patient faces, but also at the social context of their lives. I guess I would equate it in some ways to compassion, in that it's truly understanding what the issues are for the patient and going above and beyond and being persistent in helping that patient achieve health in a more global sense, not just their medical conditions, but their overall well-being. There's not any clear boundaries on that. If it's just necessary, maybe it's not, getting them the medication they need. Maybe it's helping them have the conversation they need, helping them access the information they need to get a job, or whatever it might be that's causing that person the most distress at the time. So I thought that was a really complete understanding that resident had of what health advocacy is. She was she or he was a little bit of an anomaly in a lot of our discussions. So the question that is still a really big one is, if health advocacy were within the education system, like we're more of an institutionalized part of a curriculum like we have here at UBC, how would it be defined? And again, there's a pretty big literature on looking at the tensions between making it more on the kind of political advocacy side or more on the individual side. And what I have seen looking at websites of different educational systems that have health advocacy is that it's leaning a lot more towards the individual patient advocacy side. So right now that's where we're at. So we're doing these interviews that I've mentioned. We're interviewing residents, and we're trying to find out really what is it that would inspire people to do something that is quite new, given that there's already too much to do. And like Shafiq and Ian's study, we're using a qualitative methodology, and we're asking people questions like, what made you inspired to become a health advocate? Who inspired you to become a health advocate? And so right now we're analyzing transcripts and looking at those. What inspires residents and practicing physicians to be health advocates? And what we found, it's probably not surprising, is that when we ask people, so how did you get onto this track? What made health advocacy interesting for you to do? Very few of them, although some did say it was medical school, very few of them said it was medical school. So that's a really big lesson for us as educators. What are we going to do with that information when we know that people are already coming into medical school with these ideas that they want to do more than just medicine, that they want the altruistic humanitarian aspects of medicine to be a bigger part of their professional life than the purely clinical work. People are talking about how they got inspired from their mother or their father, from being across the world doing work in another place. And then some of them do talk about mentors they've had. And some of those mentors do come from within medical school and sometimes from within residency. So we have learned that mentoring is an important aspect, and certainly preceptoring is really important. So if by the luck of the draw, a resident or a medical student gets a physician who's already doing work with the homeless or doing work in an inner city community, then they've gotten inspired in that way from those people. But there's certainly nothing in the interviews that we've done so far that has seen a systematic approach to learning health advocacy. It's just kind of this idiosyncratic way that people learn it from their lives. And so we're looking at trying to find ways that would inspire residents beyond, within medical school, that builds on these kinds of experiences that they've already had. So we see some places where we can do that. So as I mentioned, mentoring is already an important place that we are seeing that we could put some attention. And there's certainly a good literature on mentoring, and we'll talk about that. But what we are learning is that at this point, mentoring and health advocate mentors within this part of the world are not the norm. So that's another message for us: is how do we maybe engage with people who are already out there to become mentors, and we've seen that. Not all students are exposed to those particular people. So that systematic approach to health advocacy just isn't happening. So how can we encourage health advocacy in medical school? Well, there are already some opportunities. Probably some of you know about CHIAS, the Downtown East Side project that a lot of our students are already doing. And there's a course called Doctor, Patient, and Society, in which particularly in the second year, students are able to do their own kinds of projects. And some students do take up health advocacy projects. In fact, a lot of Doctor, Patient, and Society projects do have some element of health advocacy in them. So working with those kinds of opportunities can help. But the question is, can we do more, and how can we do more? That's an important question for us to sort of think about how we can do that. I guess the question that arises for me when I think about medical school itself is, who's coming into medical school and what preset ideas do they already have? What we know is that when we raised tuition fees, we did get a different kind of student in medical school. We haven't seen a lot of literature on whether there were more health advocate medical students when the tuition fees were lower, but I'm guessing that we probably did see students who came from populations who had experienced some level of poverty or some level of discrimination. So does coming from that experience of some kind of discrimination make our students better health advocates? We don't know that yet. That's a question that we need to think about. And would trying to make medical school a little bit more accessible make a difference to this? These are questions that we have. So what would health advocacy in the formal curriculum look like? That's another really big question, because formalizing and professionalizing a field like health advocacy could have its ups and it could have its downs. And certainly if we were to try to tell people in a very clear package, this is what health advocacy is, I think we would take some of the creativity out of it. So in trying to professionalize this concept that hitherto has been largely done voluntarily or largely done because people feel like it's a good idea to do it or because they had the inspiration from their family or other people to do it, definitely has its challenges. And so if we are to teach health advocacy at an institution like UBC, what would it look like? And we know what it looks like in a few different places in the United States and in Latin America. It is taught in some medical schools around the world. How would we choose? So just questions. We're still at this real kind of nascent stage with this field where we're asking questions. So creating an environment for health advocacy basically is about creating an enabling and nurturing environment, starting in medical school and then continuing it through residency. We know that we want to try to do that, and we're really not sure what percentage of our students or our residents are going to come out of this whole process wanting to do health advocacy. Maybe it's going to be 5%, maybe it's going to be less. And since right now the population of physicians who we know are out there are rather small doing this work, 5% would probably be a good amount to aim for, and just keep trying to nurture even a small amount of health advocacy, and particularly when we've got the CanMEDS Health Advocate Role there to back it up. We're on a pathway to trying to bring this field alive. So we're creating this e-booklet, and it should be ready sometime in the next month, sometime this year for sure. We've done a literature review. Shafiq showed you some of the literature that's in this field. We're going to profile some of the health advocacy champions because we thought that would be a really great way to provide inspiration, asking people who are already doing good health advocacy to share some of their pearls of wisdom. What are they already doing, and how would they try to inspire others to do it? And we're going to provide some specific tools, some PBL scenarios and things like that, and then some resources. There are some wonderful resources out there like the Red Book, people who are already doing really, really good work in health advocacy. And the importance there is to tell students and residents that if you decide to make health advocacy an important part of your work, you don't have to do it alone. In fact, sometimes the greatest thing you can do is just make a referral to that crisis line or to that counselor or to that homeless shelter. That might be just a huge amount of help, just doing that simple referral, and that's actually a really important part of health advocacy. So right now we're working on getting the health advocacy the booklet completely done, and then we're going to be working on getting some feedback from some colleagues. We'll be getting written feedback, some focus group feedback, and we're really excited that our illustrious colleague here, Dr. Wong, is going to be writing the preface for our e-booklet, and we will be having a launch sometime, hopefully, in the next months this year. The other hope that we have for this e-booklet is that we're going to be doing a scholarship of teaching and learning exercise with this to see if our e-booklet is going to make a difference for postgraduate medical educators, practicing physicians, resident students, and to see if this kind of resource is useful at all. So that's a plan of ours, to ask people what they know about health advocacy prior to the release of the e-booklet and what they know about it afterwards. So that's definitely a big hope of ours to be able to do that. And one of the great joys of doing a presentation like this when a work is still in progress is that we can ask for your suggestions and ask for any input that you might have from listening to these two talks on health advocacy. Thank you.
Thank you very much. And I guess we have lots of time available for questions and discussions and so on. So perhaps let's start off by asking our colleagues from Victoria. Do you have any questions or comments?
This is an excellent presentation. My background is family practice, and I'm the course director of DPAS here. And I guess one of the main obstacles that I see is when physicians go out in practice, unfortunately, the government is not funding physicians to do this kind of work in day-to-day. And so it's our crisis line in Victoria just got shut down by the government. There's not often a lot of government support for advocacy work. So it's very important work. We all know that, and I think the big challenge is and perhaps this is in part a political part of it is that the medical school or physicians that are graduating could influence the government into how important health advocacy is for providing health care to our population.
Yeah, and I think once we really do inculcate an idea of becoming an advocate for trying to create healthier populations, then we will have physicians who graduate and do some lobbying and start to get more funding for these kinds of initiatives and do try to reinstate things like a crisis line that was helping. So once we start to see health advocacy as a skill set that is helpful for physicians, we'll start to see those kinds of programs hopefully coming back and more programs being created.
Yeah, I'd like to add that many of you know that we have a community advisory board for DPAS, and at our last meeting I heard that many organizations were affected with respect to budget cuts. And one of my suggestions, or at least something that I'm thinking about, that we need to come together around some of these emerging issues is to identify them, raise awareness among our own faculty across the various disciplines and among our residents and our undergraduate medical students about some of these issues, and then advocate for advocacy.
Right.
So, as we struggle with thinking about how do we integrate this into curriculum, I think perhaps what we need to do is to take up the role, and that by virtue of that, you're in fact, it just doesn't become a learning issue. It just doesn't become an objective to fulfill, but it moves towards being responsive in that way. So, that's something that I'd like to put out there, that, as we, on the one hand, we want to think about it as teachers and how we integrate it and to meet accreditation standards. On the other hand, these issues are real, they're happening now, and here's an opportunity to take these issues up and be a part of the response.
Yeah, I think that's an excellent idea, the idea of advocating for advocacy.
Yeah.
That's great. Well, thank you, Victoria. Let's now go on to UNBC in Prince George. Do you have any questions or comments?
Well, I'm guessing a thought on a lot of people's minds is, what are some ideas for implementing this role or teaching this role? Can you give us any kind of a preview on some of the things that might be in the upcoming primer?
Sure. Well, we have lots of different kind of pedagogical tools that people can implement with their students in the classroom, different kinds of interactive learning exercises to teach issues around inequity and inequalities. If we really want to get at the nugget of social determinants of health, it's really important for students to be able to understand inequities and how sometimes the rules are just not fair. And no matter how hard some people try, they're still climbing to try to get to the same level as other people are. And so some of these exercises that we have, one called Star Power, another one called Archie Bunker's Neighborhood, looks at basically gives the participants a scenario, a sort of a game to play in which the rules are predetermined to be unfair and gives people a little taste of what it's like to be an underdog. And when people get that experience of being an underdog, they get a little idea of what we're talking about here. Because what we do know is that most of our students and therefore most of our residents come from fairly privileged backgrounds. So some of these exercises are trying to give that experience of a little bit of suffering. What's a little bit of suffering like, and how does that feel?
And perhaps if I may add, from a residency point of view, certainly as a program director for internal medicine, what we have been doing is to engage our residents in actual action. So what we call the curriculum is advocacy in action. Our residents, through community networking, will go out to the community in small groups to self-organize health promotion and disease prevention activities. So our focus seems to be health promotion and disease prevention. And these activities are all spearheaded by residents themselves through their community contacts in different subspecialty areas. In order to draw on knowledge learned in the medical expert role, they go out to deliver specialty or content-specific talks. So, some of our residents have gone on to talk to South Asian communities about hypertension, Chinese community about dementia prevention. I think they have gone to halfway houses. They've gone down to Insight. Certainly we have a variety of different activities, cancer prevention camps through the Cancer Society, etc. And in doing so, they engage faculty people who are already sponsors in those fields, and they are content specific. So I think this is the higher level of advocacy. I do not anticipate med students will be doing that, but interestingly, sometimes we're surprised that, in fact, many med students in the pre-med years have done activities like that in order to get in med school to start with. Yes. And yet, during residency, for a variety of reasons, maybe the environment is not conducive, etc., then activities fall up quite dramatically. So what we try to do, you talk about an enabling environment, we basically provided a framework without specifying exactly what they need to do. Although every resident in internal medicine knows that they have to do one activity in their 3 years of core training as a promotion requirement. Mm-hmm. So it is mandatory, one shot in 3 years, they can do anything in the 3 years. So hopefully that gives you some idea about, from a residency point of view, kind of a higher level of health advocacy. And is actually received very well by our residents.
I also add that through my research, I'm finding that, or at least I'm suggesting to program directors to use more of a participatory curriculum approach as opposed to taking a hierarchical top-down approach to curricular development or integration of some of these non-medical expert roles into the curriculum. Engage their residents, ask them how they want to see this done. We can also look at the scholarship model. Most, if not all, of our residents have to do a research project before they complete their residency training, and to begin to explore with them how they might integrate the health advocate role within that context. One discipline, because of some of the half days that we did together, has decided to block off some time to do health advocacy related projects, and then to even create opportunities to link the scholarship component to that. I think that residents already feel that this is an add-on, that this is going to take away from time or add more stress, and that's certainly something that you don't want, because that would defeat the whole sort of approach to health advocacy. Our residents, particularly in the surgical disciplines, who hardly get sleep, and that's how their discipline is structured, have said that, how do you expect us to be advocates for others when we ourselves feel like we need advocacy for, and so those are very important, I think, and insightful comments, that you can't teach someone to be compassionate if your training in and of itself is inherently disenabling from that perspective.
Very good point. Without belaboring too much, I think advocating for residents is something that perhaps the residents can do. An example that came to mind actually in our internal medicine group is that a couple of years ago, a group of residents felt that they feel disenchanted when they're talking to patients who do not speak English or minimal English, who speak mainly Chinese, Cantonese in particular. So a group of residents got together and formed a medical Cantonese course teaching peers and fellow residents on how to do that. They actually did a scholarly productivity. They produced a paper out of it because they were pre-test, post-test, and it with blinded raters and all that. And I think that paper is being produced as we speak. So it's actually a very good idea. You can mix and match the CanMEDS roles. The key, though, is you have to encourage innovation and creativity from residents and try to support them with the right resources, because I think our residents are very resourceful, and this is something that initially I thought, yeah, that's a cool idea, but as it turns out, it's more than a cool idea.
Just want to add to that many residents have also said to me that they've never had an opportunity to meet fellow residents in other disciplines, and that there was some suggestion that we might look at advocacy initiatives by building the collaboration. Again, the collaborator role right there comes into play. So you can see that these don't have to be standalone, siloed roles, and that our residents have a lot of knowledge to offer and how we can enhance training.
Right. Let's go to Kelowna and see if you have any questions or comments.
Hi, it's Cheryl Holmes. I have a question and a comment. The first question is, you said something very, very interesting. Professionalism undermines health advocacy. Can you explain that concept?
Oh, I don't think I quite said professionalism undermines health advocacy.
Well, that's what the slide said.
Oh, sorry. So that is definitely what one of our interview participants did say. So the idea of taking something that currently is done out of altruism and volunteerism and making it into a professional, curriculum-focused, formal exercise could take away from the spontaneity and the passion. Because most people who do health advocacy are basically really passionate about trying to make the world a healthier place. So if you try to kind of make that a very dry, easily defined subject matter, you're gonna undermine it. So I think that's what that quote is about. I actually have a book on the professionalization as a topic. So it's a very important question when we take activities that are outside in society that people do all the time, because their health advocates are not just physicians. In fact, you could plausibly argue that most health advocates are not physicians. The people who are already doing work to end poverty and who are trying to raise the status of women, or trying to raise the status of people with disabilities, or trying to change conditions of water and sanitation in a village in Thailand, those are the majority of health advocates. And they don't necessarily even see their role as being health advocates. That's just what they do because they want to make the world a better place. So making this a professional thing has its ups and downs.
Yeah, actually, what's emerging in my study is program directors are saying that they would not want to see the health advocate role trivialized by formalizing it. In other words, accreditors are looking specifically, it's sort of, if you take a bean counting approach, how many lectures have you had, how many activities have you had? Yeah. Some program directors said, like, what am I supposed to do? Say, stop, say, okay, now we're going to stop and talk about health advocacy. They felt that was sort of essentializing and trivializing it by drawing sort of attention to it in a way that didn't seem natural and didn't seem a part and parcel of what you did. So, I think that one way it's been phrased is trivializing it by formalizing it and drawing so much attention to it so that you can justify to accreditors and others that you're in fact meeting these competencies. So we're going to have to find a balance in how we do.
And essentially what our hope is that physicians will see it as their big picture vision of their career to try to make people healthier. And what the literature suggests is that the roots of health do lie in these social issues. Medicine plays a huge and important role, and so do these other roles. So if we can somehow dovetail all of this kind of work together, that's what we want, is this integration of health advocacy into every part of what physicians do that's relevant.
Okay, and I just had a comment, just to remind us that not everyone defines health advocacy the same way. I had a surgeon say to me, yeah, it's all fine for the anesthetist to go to Nicaragua to do a project, but they won't stay an hour late and make sure that a diabetic vasculopath gets a vascular access before tomorrow morning when her hemodialysis is due. So people define it different ways.
Yeah, that's an excellent point. It reminds me of another example from my study where one colleague asked another, you're doing a stent on a 90-year-old? What's with that? And the other colleague who was preparing for the stent says, I don't know, I was just told to do a stent and that's what I'm doing. And Boyer talks about the disastrous divorce between competence and conscience, that once you start to practice, you stop thinking beyond the technical aspects of your work. And so that was quite an insightful comment that I've
Although I have to make a comment as a geriatrician that there's absolutely nothing wrong about standing a 90-year-old person.
Oh, sure.
Right, Cheryl? And ICU patients as well, right?
But I think you do raise a really important point, and that's why I spent a significant part of my presentation talking about the definition of health advocacy. There really is in that definition a huge debate, and it's a debate that is connected to many other debates that we're having in the world. What is the role of a professional? Is it to work at that level where you do wait until your patient's care is completely done and you're really sure, even if it means that your dinner's waiting on the table and that your family's waiting for you, that you're sure that your patient's okay? What does health advocacy mean? So I think what we're coming to is what we're seeing, that there's a spectrum of what health advocacy is. There's a range. All of these things can be health advocacy. Doing political lobbying, standing up for your patients, it's all health advocacy. So we're coming to a place where slowly we're going to start defining these without trying to make them too static as definitions, right?
That's great. Let's try to go to Children's Hospital. Do you have any questions or comments?
I don't think so.
I think you're okay there, Joan. We can't hear you, but welcome to our rounds. Okay, I guess in Vancouver here in Diamond Center, any questions or comments? Yes,
I have a
Stefan.
comment. Hi.
Please do.
So I think that there seems to be a general agreement that there's a difference between advocating for individual patients and trying to get at the root cause of disease and looking at populations. That's part of this. I think there's also a dichotomy between people who are going to be expected or who want to do health advocacy as the main chunk of what they do and how they spend their time, and the sort of day-to-day health advocate. So this 5% number that you brought up of, if we just got 5% of people thinking about health advocacy, I think that's maybe setting the bar too low.
Okay.
And your other comment about integrating it into the other roles, I agree with much more. I think that they're all, like the flower, this CanMEDS flower, it's all one unit. And to do any of the other roles properly, including communicator and scholar and expert, you need to also be doing health advocacy all the time. So I think we need to set that bar probably much higher.
Yeah.
And the health advocacy champions that we find that'll be highlighted in this primer or whatever, those people, sometimes it's very intimidating to sort of read about these people.
Yeah.
Because you think to yourself, well, I can never do that. Like, I'm not going to do 80% of my work doing this other thing, but I need to see a health advocate champion who's just really conscientious, like whose manifestation of health advocacy is just being a all-around solid person.
Yeah. Thank you so much for those really important comments. I'm really encouraged to hear you say that we should set the bar higher, and I certainly would love to set the bar higher. I guess I think it's just really important to be humble and modest and realistic in this field, because what we have found is that there still isn't this huge body of literature on health advocacy and how to teach health advocacy. And there certainly isn't a huge body of practitioners doing this stuff. In our interviews, what we have found is that there's still a real vague understanding of this field. And in practice, there isn't as there's not a lot to go on. So we're just trying to be really humble here. And if you think setting the bar higher is good, I'm totally with you, 100%. Shafiq and I have had numerous conversations about your other comment about who to profile as a health advocate champion, because it's very, very easy to pick the international stars. Everybody knows who they are, and those are the types of people who are really inspiring to some, and yet other people might say, oh, I can't do that. That's not me. I don't see myself in that person. So we've really talked for months about what kind of profiles we should do, who we should profile, because what we do really want is to inspire everybody and anybody who wants to do health advocacy to see a little bit of themselves in that champion, to be able to say, yes, I can do that, that's me, and I can see myself being there doing that. So we have definitely moved more towards the position of going towards the everyday health advocate who's in their corner doing their work, and yes, you and we can all do that. So that's definitely the area that we're moving into. Not to negate the important work of those big international stars.
Right from the outset, I had the conviction that, if I asked you to mention a couple of names of some of the very prominent people, what names might you throw out? Throw out a name. What comes to mind?
Norman Bethune?
Okay.
Yeah, great.
Julio Montana,
Yeah.
present day.
Current
John
day.
Blatherwick,
Yeah.
right? And you're right. It can be quite intimidating because it's a career shift, really, in what it is that you do. And we wanted to make sure that, particularly as we think about how do you integrate this into training, that you want to be able to identify people that you perhaps never even thought about, because they do it in a way that's part and parcel of just like your everyday physician, your everyday surgeon, and there is no level of advocacy that's too small, but it's sustained, it's systematic, and they have a clear sense of how it impacts on the lives of their individual patients, families, and perhaps even in the community. And that's what we want to. So if you have suggestions, and you won't find those people, and so we're trying to use the snowballing method to say, do you know anyone that we can speak to? And when you do go and speak to, we found one or two, they're very reluctant to be profiled, and understandably so. But in the interest of enabling sort of an educational approach to say, look, here's someone right next to you, and these are the resources that they use. These are the ways they think about this. And if you ask them, they would never say, oh, I'm fulfilling my health advocate role.
Yeah.
And I think that that's the key.
Yeah.
And thank you for all those comments. And I guess before giving my concluding remarks, if I were to try to attempt to answer your last question, I have two suggestions in terms of names, and both of these are residents. I think you will find it very helpful to profile residents who have demonstrated their health advocacy roles. And both of them are not here, so I guess I can volunteer them. One is Dr. Jocelyn Chase, who is the current chief medical resident in the medicine program here. And the other one is Dr. Dave Sohi, SOHI, who is also an internal medicine resident. He's going to be, he's a second-year resident in our program in medicine. But the reasons why, and if you ask any of the colleagues in terms of naming names, residents who are champions for advocacy, I think those names will pop. I think the strategy is to profile, I agree with Stefan, someone that you can see yourself in. And no offense to the big names, but I mean, even as a staff member, I have difficulty identifying necessarily with, stuff, with Julio or whoever. But I think the other thing I do want to say is, this has been a very rewarding round. We do want to say thank you for both of you, Shafiq and Farah, for joining us today and sharing your wisdom with us. I think probably sometime in the future would like to invite you back to share with us your finished product and as well as some of your future findings. For those of you who join us late, again, if you're interested in identifying and knowing who the winners are for the teaching tip contest, they will be posted on the Faculty of Medicine homepage website after 1 o'clock today. I've asked them not to release the names until we get a chance to disclose it here. So probably when you're done here, it will be on the website. I want to say thank you very much and have a good day. Bye-bye.